So can you hear me clearly?
I can, yes, go ahead, start share your presentation.
Okay, excellent. So thanks everyone. My name is Waleed and I'm one of the anaesthetists. I do welcome you and now talking to you here from Melbourne, Australia. Today is Sunday, the 14th of June, and it is 6 o'clock in the morning. So if you can see me clearly, that's perfect. If you can't, I do apologize because there is no much light here. I will stick to the time and I'll be starting this lecture in the name of the Lord, the most gracious and most merciful. And I would like to share with you the topic today, which is about communication. Communication is one of the soft skills that we all need in anesthetics. It's not a luxury to have, it's actually a must because it will impact on the patient care. So before I start, there is a bit of a disclaimer that I would like to say. To start with, I don't have any financial interest in this lecture or never had any financial interest in education, but you will notice that I am biased whenever I talk about Australia because we keep pride in the level of medical care that we provide and we receive here. So it's something that would make me kind of naturally biased. Today, we are going to talk about the communication, and there is a big reason why I'm involving my phone number and my email, because I'm very happy to be contacted because the education doesn't really finish here. If any questions happens in the future, I would do welcome people contacting for any clarification. Also, you would notice that when I talk about my employer, which is Werribee Mercy Hospital, it's actually a pleasure to have such a supportive employer, so much so that we as anaesthetists, we dedicate ourselves to our profession. And it's very nice to find a setting where your employer actually supports you at all times. That helps the team player, so much so that I would very happily say that when I go to work, I'm having so much fun that I'm wondering why do they actually pay me? Anyway, we'll get into the lecture now. My vision has always been to reach where I am now in terms of reaching a level of contemporary medical practice possible on earth. And that vision, to explain why and how I reached there, I'll just give a brief background about how it started. So I come originally from the Haram district, and there are so many tourists and people there. And one of the things that has always made me think, how do those people communicate from different backgrounds and different sort of languages, and how can I reach my goal to practice in an environment where I have the best access to the most contemporary sort of medical practice. So, and that is the importance of the communication, because with the communication, I managed to achieve where I am now. So this lecture is a practical application of what I personally experienced. I have, as mentioned, graduated from Cairo University in medical school, and I have developed my communication skills as time went by. And I can guarantee to you that this lecture, or part of it, will totally change your communication style, plus or minus your life, if you're open for the change. As Dr. Waleed has mentioned, Waleed Al-Habashi has mentioned about the 2 books that I have published for the ANSCA primary exams candidates. They are absolutely free, and I'm very happy to be contacted to give away the books, and also happy for Waleed to give the books for people who are interested. Please share them, the more the merrier. And we, in our talk today about anesthesia and communication, we are going to talk about clinical stuff in anesthesia. The talk is going to be about communication in the clinical setting as well as in the education setting. But by all means, feel free to extend or to like project this, what you've learned today or what you decided to absorb today in your personal life. One of the examples that I would say and share with you about how I communicate with trainees, for example, and same thing I can actually use this and have been actually using it for dealing with kids, for example, at home. Just before I elaborate a little bit more on this, as a FANZCA or a fellow of the Australian New Zealand College of Anaesthetists, I am actually using the slideshow of the college, but anything that I express here is purely my vision and my opinion, and I take full responsibility for it. So back to the communication. When I speak to a trainee or speak to my son, whatever, and he comes and tells me something, because I live by the say, which says nothing is good or bad, but thinking makes it so. So
I'm sorry to interrupt you. Are you planning to share your slides? I'm sorry, we don't see your slides. Are you intending not to share them, or it's just missed? I'm sorry for that. So
no,
your slide.
Okay. I think I've missed it.
Okay, so if you go to share a screen. Yeah, if you
could you please guide me where?
Yeah, share screen. Yeah, and then share your desktop.
Sure.
Perfect. And then play. Yeah.
So, have you actually heard anything of what I said earlier?
Yeah, we heard everything, but I know your presentation is not like it's fine to start the presentation from now. We can do playing it. Okay. Yeah.
So you heard what I mentioned so far, right?
Yeah. So your voice was absolutely clear, but just the presentation was missed.
Okay, so now can everyone see my presentation maybe?
Yeah, that's absolutely perfect.
Oh, that's fabulous. Thank you so much. And I do apologize for the technical error. So basically what I was mentioning is about nothing is good or bad, but thinking makes it so, which you will see that as on the top of any of email I communicate. And that is the thinking is a way of communication. And I do encourage all my trainees to think, also my kids. And one of the take-home quick strategies is the simple sentence I mentioned, which is, say, for example, someone comes to me with something saying, I've done it this way. There's only one sentence that I say. What do you think? Is it good or bad? And I stop for a second and give them an opportunity to think. Then I add, I agree. So say, for example, my son comes to me and says, I scored C in my math or whatever. I don't judge. I say to him, what do you think? Is that good or bad? And that gives him an opportunity where he thinks and say, well, I suppose it's good. And I say, why would you think so? Or he says, oh, it's bad. And I say, I agree. So pretty much I am encouraging the person who is receiving the communication to make the decision, to get him on board so he can actually think and he can actually reach the opinion. And all what I say, whether it's a trainee or my son or a colleague, I say, what do you think? Is that good or bad? And that gives an opportunity for them to actually put some thoughts. And then I say, I agree, if I do. Or I say, why, what has made you think this way? So that would encourage him to actually think. To know how we think, it's actually very important to know who we are and who is the other person that we're communicating with. One of the tools that I use, and I do encourage people to actually do a little bit more of research about it and know how to communicate, is through what's called the MBTI, or the Myers-Briggs Type Indicator. It's a personality test that shows the 16 different types of personality, whether you are an introvert, extrovert, you're a sensing or perceiving. You can Google that. The topic of this is way beyond the scope of this lecture, but it's very important to know your type, so you know how people communicate to you. And you, with time, will be able to know other people's type just by looking at them. And then you can communicate in a more efficient way, because every one of us has different expectations. And the aim of the communication is to reach people's expectations and make this interaction a very useful one. I'll give an example now to see how rather people during communication, they actually see their experience. They don't see or hear what you say. Sorry. So for example, if you would like to see what's expectations and what people see, you can imagine a table, and on the table, everyone is sitting in front of his plate. Your plate is your experience, and that's what you see. So reality is the whole table, but what you're only seeing is that part of the reality that your plate is occupying. So it's very important to expand your plate or your reality so you can see how people see things. One example is in one of the hospitals I was practicing, I do lots of obstetric anesthesia, and the midwife was asking the lady, the patient, and we have a multi-ethnic community here. Lebanese lady, the midwife was asking the patient, who's a Lebanese lady, and she's saying to her, "So, Mrs. Whatever," and the lady recognized her name, and she said, "Yes, yes, I'm my name, but possible with me, Yusuf." And the midwife said, "Yes, yes, hello, nice to meet you." And Zainab, or the patient, at her husband, and she said, "And this is my husband, he's abusive." And you can imagine the silence in the room. You can imagine the tension that suddenly happened. "This is my husband, he's abusive." The midwife was, "Are you right? Is everything okay?" I heard that conversation and I stepped in. Abu Yusuf means the father of Yusuf. It's not abusive, means abusive, as in abuses people. But the midwife views that as this man could be abusive to his wife, who's pregnant. And that's kind of a domestic violence issue. So the midwife felt an obligation that she should actually report that. When the whole situation, she's saying, "My name is Yusuf, and this is my husband, abusive." Anyway, so that's an example. People would see what they perceive. And it's very important to acknowledge and understand that communication is about the receiving person. So for example, you might see someone with a beard. You might think, oh, like you interpret it your way. Is that for religious reasons? Maybe he has some sort of skin allergy, or maybe it's a fashion. The person didn't do anything except then growing a beard. It's up to you or up to the recipient to actually interpret what he's seeing. Similar, people, would they think of Australia, or they hear Australia and New Zealand College of Anaesthetists, they think Australia and New Zealand are kind of the same country. Absolutely not. Absolutely not. Totally different countries. Friends, maybe, but it's two different countries. So when people imagine Australia have some sort of a prototypical picture, no, it's different, but people perceive the prototypes usually general in life. So during our communication, I would like to emphasize on the importance of body language and also the tone, how things are said. This is very important because in my years of training, I'm Australian trained. In my years of training, I've encountered few interesting experiences, which let me share with you. One of them is when I was starting my training, and my supervisor at the time, he said, "Waleed, you will pass the exam you really well when you understand the lingo." I said, "What is the lingo?" And he said, "You're not ready." Lingo means language in local term. So it's when you understand how people think locally and how people talk locally, you will be able to bond with the patient and your colleagues, and you will be able to actually efficiently communicate, because communication is not about the person who's talking. And that's the take-home message. Communication is about the perceiver. And that's why we need to put ourselves in the shoes of the other person. I'll give an example for those who might come from an Egyptian background. If you, for example, jump in a taxi in Egypt and someone speak to you, the taxi driver, and say, "Ah, how's things?" And you say, "Masr helwa ktir," people will know immediately that you are not Egyptian, or you're not lived in Egypt, or you're coming from overseas, because the term helwa ktir, which means very good, is not a term that's commonly used. You'd say baladna gamila or Masr gamila, but you wouldn't say something like Masr helwa ktir. Similar, when you are in Australia, for some reason, the the tomato, it's called tomato. Once you say tomato, people wonder, sorry, what do you mean? What's tomato? Well, tomato is more of an American thing. So what is it? It's tomato. Why do you call it tomato when you actually call it potato? You don't call it potato. You know what I mean? So it's very important to be able to understand the local accent. You can even learn few accents as time goes by. And when you use your accent, bonding with your patient, that makes the patient feels at home. So for example, if I am like a situation where we put a patient to sleep, patient is waking up. When the patient is waking up, whether we're taking the LMA out or sedation or extubating the patient, we've been all there. And very important to give the patient some sort of orientation, because he doesn't wake up to my face every day, or she doesn't wake up to see me. So it's very important to give a little bit of orientation. Mrs. Smith or whatever, you are in this hospital, you're waking up from your anesthetic. I even go a step further, and you can even talk to them in their own accent. That makes them understand it, because people like to know and like to hear what they are familiar with. One website, I don't promote any websites, but one of the YouTubers on YouTube, which is the channel is called English with Lucy, would help you to change accents and to be able, for example, to communicate with people from different backgrounds and understand what the other person is talking, because English is not only one accent. So that's one of the things, and we'll make it even familiar for your patient when the patient is waking up. So if I'm, for example, waking up like an Australian patient, I would say, open your mouth, you're waking up from your anesthetics, eyes wide open, very well done, excellent, take a big deep breath in and out for me. If I am waking up, maybe, for example, a British patient or someone who speaks in the Cockney accent, I would change my accent to suit that patient. So I would say, open your eyes for me. Everything went by the book. Absolutely fantastic. Take a big deep breath in and out for me. Absolutely amazing work, man. You've done amazing. Big deep breath in and out for me. So you can communicate with your patient in a way that makes it familiar to the patient. Similar is how we communicate with our colleagues and for example, recovery nurses. When we hand the patient, one of the things that really disturbs me when I am handing over the patient, some of the recovery nurses might say to the patient, are you in pain? How much pain are you in? Are you feeling nauseous? Are you about to vomit? For God's sake, that's all negative sort of energy and negative sort of input you're giving to the patient. If I say to you guys, please do not think of the big pink elephant. What are you thinking of now? The big pink elephant. So another way of saying it to the patient, you look amazing. Is that how you feel? Or you look wonderful. Is that how you feel? You look wonderful. Is that how you feel? So the patient is hearing amazing, wonderful, and yeah, I am good. If they are in pain, they'll express that. But instead of suggesting to the patient, how much pain are you in? Not necessarily everyone will wake up in pain. So it's very, very important to know what is communication and how can we apply it in clinical practice. Communication is totally different from waste of freaking time, or the term I coined, waft. So communication in the academic definition is the exchange of information to achieve a goal. So we, like the anesthetist and the patient, or the anesthetist and his colleague, are exchanging information with a goal to be achieved. And very important to understand that when you communicate, it is about the recipient. It's not about me. Whatever I say, it's not going to be perceived unless they decide to perceive it. And that takes us to a very, very important point, is which one of the really words of wisdom I've learned in life and applied it heaps in my practice, is that you will never, ever get what you want till you give your team what they want. I want to be a good lecturer. I'm one of the, I do lots of teaching. I want to be a good teacher. I want to be a good lecturer. How can I get that? There is no way that I'll get that unless my team, who are the recipients, who are the listeners, get good teaching. So they are here to ensure that their time is very well spent and they're actually benefiting from the interaction. So we'll always be interacting in a team setting. And within that team, very important to understand what the other team wants. The students are coming here because they want to listen to something good that make their time worth it. So I have to give them this to achieve what I want. I want to be a good anesthetist. I cannot be a good anesthetist, impossible to be a good anesthetist unless I give my team, which is the patient on the top of the team, plus everyone else in the team, what they want. When they get what they want, I'm a good anesthetist. I can't claim to be a good anesthetist if I don't serve the patient and my team in the possible expected way. At the end of the day, it doesn't matter how many titles you hold next to your name. It doesn't matter what position you hold in your employment. At the end of the day, we are public servants. We're serving the patient. So it's very important that when we team up with the patient and our colleagues, that we make sure that the recipient receive what they want. That would make you a good anesthetist. And in understanding the communication, very, very important that we appreciate that communication is a dynamic thing. So dynamic thing meaning that we are always talking about the helicopter view. Things are moving up and down. We're not talking about the bird's eye view where you're seeing everything in the field, yet you can't have good attention to details. Sorry. And we are not talking about a treetop view where you're seeing details, but you're missing important aspects of the field. It's very important to actually make the communication in a helicopter view and maintaining this situational awareness, going up and down, up to the bird's eye view when needed, and coming down to the treetop view when required. One example is, and I actually come across that repeatedly in medical school exams as an examiner, is how to consent a patient. And I find that half the mark is actually for discussing the risks and benefits of the procedure. That's only half the mark. The other half is to discuss with the patient not having the procedure whatsoever. Like when we consent patient, we talk about risks and benefits. Yeah, great, you've done fantastic. That's half the mark. The other half is for what if you don't have the procedure. And I remember a patient one day when I was consenting him for blood transfusion, he was pretty much dependent on blood transfusion. So I said, could you sign this consent? This is the benefits, this is or whatever. And I talked to him about not having it. And he said, doctor, I don't have a choice. Just give me the piece of paper to sign. And I said, no, you actually have a choice. You can choose not to have the blood. He said, but I'll die. I said, yes, and that is a choice. You are making a choice whether to have the blood or not have the blood, knowing the consequences. Whether you have the blood, there's consequences. If you don't have the blood, there's consequences. It's totally up to you to actually make the choice. Life is all about choices. Also, in a setting, in a clinical setting of a CPR or resuscitation, we've all been there. We're being called for an emergency to resuscitate someone. Very important to optimize the communication. Once again, it's for the patient's best interest. I wouldn't say like art line, please, or an IV access. No, 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 no. Very important to say, Jackie, would you please put an art line in the left radial artery? Or Susie, and you address the person by name, look to them in the eye and ask them to do the task and specify it as much as you can. And when you specify it, also very important to close the loop. So Jackie, would you please put an 18 gauge in the right side of this patient? IV access, please. And then you say, okay, so, are you comfortable with that? Would you do it for me? In that way, you are ensuring that the message has reached the patient, has been acknowledged, because at the end of the day, communication is about the patient, about the recipient. So once they receive that, then they say, okay, so I'm expected to do this task and I'll execute that task. And then they will let you know, yep, thank you, task has been accomplished. Same is like, for example, with inter-hospital transfer. With inter-hospital transfer, we need what I call the 4 M's, which I just like to have some mnemonics to keep things in mind. You need manpower, you need monitoring, you need medication, and you need meticulous communication. So I need to make sure that the lift is available and is empty. So when I transfer my patient, I can go straight into the lift and go up. If the patient's going to radiology, I need to meticulously call the radiology, say, we are coming, expected time of arrival is 5 minutes or 10 minutes. So we don't go there waiting for another CT to be done. So the communication, the whole idea of it is to serve our patient. And it's very important to appreciate that it is about the recipient. This is one of the take-home messages, and very important to close the loop. So how can we achieve our communication? There are particular tools that I would encourage you to implement in your practice. And as William Shakespeare mentioned 2,000 years ago, nothing is good or bad, but thinking makes it so. So is coffee good or bad? 1 is good, 2 is good, but 20 a day is bad. So the thinking is one of the integral and pivotal parts or tools of communication, of proper communication. And there are so many tools of it. It's you can search your own, you can develop your own. But one of the things that comes to my mind is, for example, the democracy tactics. Like one of the political parties would say to you, would you choose Mr. A or Mr. B? Both are our men. Both will do what we want. But when we make you to choose, you actually feel that you belong to the party. You make sure, we ensure that you perceive that this is done for you. Same we say with our kids, for example. Sorry. So I'd say to my son, would you like to have shower first or breakfast first? Well, I want him to do either. And it doesn't matter which one he does first, but I want him to feel that he's part of the choice. And I want him to make a choice. So he thinks and he say, oh, I'll have shower first, or I'll have breakfast first. If I say to him, get up, he won't get up out of bed. He doesn't want to. But when I give him both options, is a tactic of the communication. Would you like to shower first or have your breakfast first? So now he starts thinking, maybe I feel today like having my shower first. So it's one of the tools we can use when communicating with patients, because at the end of the day, when communication is done, it's goal directed. Like it's an exchange of information aiming to achieve a goal. So I have a goal. My goal is to serve my patient in the very best possible way. So that's why I want things to work for my patient. Say, for example, I encounter some sort of resistance. Well, there's no one better than us anesthetists dealing with resistance, because we know that the physiological equation is flow, which is flow of communication or flow of whatever, equals the driving pressure over resistance. When we remove the resistance, any minimal pressure will create fantastic flow. And increasing the pressure will create equal increase in the flow. Say, for example, something is out of your way, like you're dealing with something or doing a conversation and doing a consult, pre-anesthetic consult, and you have one of the medical students attending the consult to learn, yet he started to ask questions and interfered with the consultation. I wouldn't say, John, would you please leave us alone? Or I'll answer you that, John. I'll say, John, that's a very interesting question. May I ask you for a favor? Could you please print out for me something and you give him a task so he feels valued and you send him to do that task. So you kind of offsided the resistance. Then you can discuss with the trainee afterwards why it wasn't that appropriate to actually interfere with the teaching or interfere with the consult. So that's called offsiding the resistance. And all these are tools you can use in your communication. I found them very fruitful. One of the things, if we want to take the communication to a bit of a higher level and get the deal of communication, is there are 4 points that's very, very important to avoid to get the best deal out of our communication. And these 4 points is don't be defensive, explanatory, apologetic, or limitational. Waleed, could you please give us examples? By all means, by all means. So answer the question. If someone say to you, did you take the physiology book? Did you take the book? The answer is yes or no. That's the question. Did you take the book? The answer is yes or no. You, having said that, you'd find, unfortunately, many people say, no, I didn't see it. I wasn't here when did you put the book? No, that makes trainees come across as weak. And we are in the business of actually helping our trainees to become future consultants. At the end of the day, they are the ones who are going to do my hip replacement in 20, 30, 40 years. So I want them to be the best possible leaders in their field. So coming across as defensive is not a good way to communicate. The other one is to be explanatory. Once again, answer the question. Like, have you seen the next patient on our list? The answer is yes or no. Yet you would find answers like, no, I didn't. I was busy doing whatever and I had to do whatever. I didn't ask about that. When I ask any reason you didn't see the patient, then this is the time for explanation. But rushing to be defensive or explanatory does not get the best way of communication, does not make the trainee develop into a senior specialist one day. Also being apologetic. The word sorry is a feeling. Sorry is a feeling. And you say that when you're really genuinely sorry. You look to someone in the eye and express it with all your feelings. But when it's overused, like, sorry, it's not really the best way to communicate. And one of the interesting things that I find is when people be too limitational, like for example, someone is putting a drip, one of my residents putting a drip, and the patient is asking a question. The first thing the resident will say, I'm only a resident, I don't know. The word only can be very limitation. The patient want to know that he is going to be looked after by a competent medical team. So a better answer is, I'm not sure of this question. I'll ask my team leader or I'll ask my colleagues. But being limitational, I'm only whatever, or I am just whatever. These words make the patient perceive the communication as, oh my God, I really wish I could meet someone who can answer my questions and actually attend to my queries. Hence, sorry, I do apologize. Very important in our communication is to use the bonding terms. The bonding terms like we, our, us. The word you makes the other person a little bit defensive. The word you separate the team, makes you versus I. And that's not the way to communicate. A much better bonding word is we have on our list, whatever booked for today. Can you tell us what are we going to do? So using these words is very, very critical because it brings the other person to be on board. And we are all familiar with the 5 common terms of asking. I have to highlight and share with you guys that the word why is very confrontational, comes with a very strong attacking connotation. And it's not one thing I would use regularly. When you say to someone why, they will feel obliged to give an explanation, a defensive explanation, really straight away divides the team into me against you. A much better one or a softer one to use is what. So for example, someone did something, okay? You could choose to say, why did you do so? The first thing they will be defensive and say, well, and they'll start defending themselves. You can rephrase the why with a softer version and say, what for? Or any reason? We haven't used the word why. The word why is very confrontational and the person feels obliged to giving an explanation. So you could replace it with like, what for? Or any reason? And it's not any reason why, but I'm not saying the confronting thing. Similar word that I would not actually use in my vocabulary is the word but. But is a bad word. because it actually gives mixed messages. And it has to be really used in a very, very delicate way, because it wipes out everything you just said. And I'll give an example. Say you're talking to a registrar, you can say, "You are a great registrar, but," the registrar is thinking, "Okay, well, I'm not good. You're a great registrar, but there is a room for improvement." It's bad. I can rather swap it the other way around. I can swap it saying, "There is a room for improvement, but you are a great registrar." So the word "but" in any language, you will find that the word "but" wipes out everything behind it. So make sure that the negative side of the sentence comes before the "but." There is a room for improvement, but you are a good registrar. That is the positive part of the equation. If it's a struggle to use "but," use "and." You are a great registrar, and there is a room for improvement. That's it. But the word "but" itself, you would really find it used a lot, sadly. And it's giving negative connotation. And yeah, it's not one thing I would use. And we mentioned that sorry is a feeling, and very, very, very important when you do that apology or that sort of sorry, it comes across genuinely. Really, it's very important. And very important to communicate with the patient or with the team in their very basic and most acceptable language. We all have been called, those who do obstetric anesthesia have been called to a situation where a patient has a BPH on the birth suite, and the patient is distressed, lots of bleeding, there's probably parents around, mother or father not necessarily speaking the language, and they're just wondering, a code has been called, everyone is running around, is my daughter safe? And the question in their head is, what's the problem? So going a step further with the communication and with serving our patients best is to actually learn the word "no problem" in as many languages as possible. So if I'm dealing with, for example, like a Greek patient, the mom, maybe you don't speak English, so I would walk into the room and say, "Oshi problema," "Oshi problema," means no problem. If it's South African, for example, I'll say, "Geen probleem," "Geen probleem." So they understand that there is no problem. Say someone who speaks Hindu, I would say, "Koi baat nahi." They would understand, "Koi baat nahi," means there is no problem. I may not speak it with the best possible accent, but at least I've given a message to the parents in the room who are stressed. What is the problem? Why there is 10 people running and the code has been called, "Is my daughter safe?" And so forth, whether it's German or English or Arabic, you speak the lingo. And when we say speaking the lingo, one of the things that I found really fascinating and a little bit stressing is when I deal with SIMGs, which is Senior International Medical Graduates, coming to do anesthetics in Australia, they use the term drugs and medicines interchangeably. They're not. They're not. So if you ask the patient, "So what drugs do you take?" "What? I'm not on drugs, doctor." The word drugs in the Australian language means heroin, marijuana, whatever. So like street drugs, that's drugs. So you don't call it drugs, you call it medication. So what medication are you on? And I've seen it before my eyes. Like the senior registrar is asking the patient, "Well, you mentioned you had diabetes. What drugs do you take?" "Doctor, I don't take drugs." "Well, you have to take some drugs." "No, I don't have to. I don't do drugs, doctor." "Well, you're diabetic." No, it's the communication is about the perceiver. You're like saying to someone, "You're diabetic. What heroin do you take? Do you take heroin? Do you take morphine?" No. So it's called medication. So it's very, very crucial, very pivotal to actually use the right term and the right accent and the right setting to communicate with the patient, with the patient efficiently. Feel free to use mnemonics as long as you actually remember what is the mnemonic that you're using. There's heaps of them. One of them is teamwork, together each achieve more, very common one. One of the things that we use when we teach regional anesthesia is simple. I know the word simple is spelled with an S, but for teaching sake, pretty much everyone knows that simple is you obtain consent, IV access, monitoring, positioning, local anesthetic, and evaluation. So things that you'd remember, one of the common ones is the SMART mnemonic. I found that this particular mnemonic actually has differences in terms of what it stands for. It basically means if you have a task, whether to communicate it or to teach it, it has to be specific, measurable, and achieved, and rewarding in terms of cost benefit and time. So someone who would say like, I want to quit smoking, or I want to lose weight. Okay, so how much weight do you want to lose? And how are you going to measure it? And is that achievable? And what sort of rewards would it actually worth it for you, cost effect, and over how much time? Same with when you counsel patients for giving up smoking. Building on the communication to reach the best possible level to be future leaders, I would like to share with you guys the 5 pillars or the 5 tools of how to be a good leader. Because people think, I will be a leader when I'm a senior specialist. No, you can lead in any position. In fact, the 5 pillars of leadership, which you can use your communication to achieve, is number 1, position; 2, permission; performance; people development; and personal charisma. Can you be more specific? Absolutely, it's a pleasure. When you are in a position in a team, you actually have 20% right to lead. So you don't have to be the boss or the team leader. You can lead parallel. If you work in one theater, go and check on your colleagues, how their list is going. Do they need help? That's parallel sort of leadership. So if you can lead from the bottom. You can say, okay, is this list going well? Do you want me to do other thing in another list if a registrar or a resident is speaking? So you can lead from the bottom. Just by being part of the team, you ticked one of the boxes to be a good leader. So your contribution to the team will be valued. So you say, okay, well, anything else that needs to be done here? Can I go and help other theaters? Being part of the team, just by being part of the team, you've achieved 20% of your leadership, and you can practice that until later. Also, very important to get people on board. So say, would you like me to do anything for you? Or do you mind if I ask you a question? That makes people keen to actually come on board. So when you get people's permission, they kind of saying, yes, please, please, I am yours. So asking for a permission develops your leadership skills. Some people rely on the performance. Like if I do well, everyone will just follow me. I'm great. Yes, this might be one of the tools, but don't totally rely on it. Like I'm a great surgeon, everyone should listen to what I'm saying. Yes, they might be, but you have missed 2 other important factors, which is being in a position and actually getting people's permission so you can lead them. Also, the 4th thing in using the communication is to give people positive feedback. Ensure that your assistant tomorrow is much better than himself today. Make people develop. So you've done great, John. That was absolutely fantastic, 10 out of 10. I would improve in whatever that we've done. Remember when we put the patient to sleep, would have been better to put the BIS monitoring, say, for example, before the induction. I think that would help us in the future. Once again, you're using us and you're giving positive feedback. So you're making the person feel valued, and also you're making the person keen to develop. And tomorrow, I'm going to apply this. The last thing of how to use your communication to be the best possible leader is by having this personal charisma. Some people might say, okay, but charisma is a given thing. If I don't have the charisma, how can I develop it? In a nutshell, if you want to develop a charisma, put genuine love to your team. That's it. When people feel loved, they will follow you till the end of the world. When the patient feel that they are loved, you have their best interest at heart, they will say, whatever doctor, I trust you. And why would you want to lead a team if you don't love them? So I love my patients. I feel very grateful for my patients. If it wasn't for them, I wouldn't have been able to to maintain my skills. I love my students. If it wasn't for them, I would have never been a good lecturer. So I benefit from them, and clearly by giving them what they want first. I will conclude this talk by this verse from my holy book, which basically translates that it encourages people to improve their communication and seek behind the scene and actually verify any knowledge that's perceived. So it says, or you believe, if you receive any information from untrusted person, go and check it out, because you don't want to end up in a situation where you hurt someone without knowing and regretting that in the future. It's in the Holy Quran, chapter 49, verse number 6. Thank you so much. It has been an absolute pleasure to talk to you all. And I really hope that some of this would improve our patient communication and help us to serve our patients better. Thank you so much. Appreciate it.
Thanks very much, Dr. Walid. And I would guess we have been a bit late because of the opening ceremony of the first session. So we should be more strict with the time later on. So we'll give 15 minutes for the questions. So if we have any questions there,